In huge classrooms like this, generations of doctors began their careers. Medical training has scarcely changed since the beginning of this century. Med school has meant countless hours in a painful struggle to memorize an endless litany of facts and figures in subjects ranging from anatomy to psychology. In recent years, this approach to medical education has come under fire. To its critics, it's much too passive a way of learning. Of the vast amount of information learned, much of it is irrelevant. Most of it will be forgotten soon after graduation. At the medical school of McMaster University in Hamilton, Ontario, the grueling schedule of classes and cavernous halls have given way to a much more intimate and a more active way of learning. Today, it's impossible for a single doctor to know everything. More and more, life and death decisions are made by teams of specialists rather than individual physicians. The perception of the doctor as a trusted friend is changing to that of a more technical and a more impersonal professional. Patients now share the benefits of medical science that open a living window on the human body. But medical educators know that doctors today must devote more and more of their time just trying to keep up. Dr. Jack Diamond, neurosurgeon.
I always hesitate to go to doctors anyway because, you know, they have to spend so much time learning things that they don't have time to think.
It has a very characteristic gross appearance.
The pressures begin when medical students are confronted with a staggering volume of facts and figures. Critics say that this turn-of-the-century learning style does not teach the skills required in the new information age. Also, this ritual does little to nurture the understanding and compassion so essential to the art of healing. This student doctor is part of a revolutionary approach to medical education at McMaster University in Hamilton. The new program is based on self-directed instruction.
Just feeling for any little flips there. Okay, great.
This is an active rather than passive style of learning. It puts a premium on ethics and sensitivity in the doctor-patient relationship. At McMaster, there are no classes, no formal lectures, and no exams. Instead, students work together in small tutorial groups where they are encouraged to study on their own and to think for themselves.
And so that's where it gets dangerous. It's always an advanced case when you find lymph node there enlarged.
Just because of the anatomical pathways to flow.
But what I was wondering is finding a lymph node there, if it was esophageal cancer, would not necessarily be an indication that it's as serious as finding it there if it's breast cancer.
Oh, I see.
That's
Because
what
I
I was
am on the
wondering.
distance for
Sometimes it's actually working on the metastases, it causes pain.
Why?
And that's usually an indicating that it's working. That's
Is that on the side of the lesion? I read about that.
If it hurts, it must be good for you.
Yeah, it's an indication that it's actually good treatment if it's causing pain. But I guess in some cases, the pain is not...
You have to look into the mechanism of estrogen. I mean, I'm sure it has widespread effects.
Not necessarily.
No, but this is an anti.
In this tutorial, the problem is breast cancer. It's a process of guided discovery. Students are responsible for seeking out all of the information relevant to the problem, while the faculty tutor provides the professional guidance.
Going to talk about different approaches to cancer would be more valuable to you rather than going for hormonal treatment, which is one part of the whole thing and one of the least effective anyways.
They're actually much better than the faculty. They become very skilled. When I was a tutor, I got back to my office once and there were 3 students waiting for me, and they insisted that we took an hour off while they taught me how to be a better tutor than I was. And they were very good, very tactful. They said, you know, this must be hard for you, but don't feel badly about it. But you're not really, you know, you're coming on too strong, you're taking over too much. And they were very good, excellent. So, the best tutors are the students, really.
And that's why he said it was important to do an examination of the mouth and the nose when you have lymph node enlargement.
Mm-hmm. I said that yesterday.
So that's why I said that it might reasonably be a common sight.
The other thing is, though, that in cases where it's specifically from the breast, it doesn't drain from the breast, it drains from the axilla.
Yes.
So that the thing is that if you do find one there and you know it's from the breast, you know the axillary, you know the axillary lymph nodes are also involved. Right. It comes from the axilla.
The level of expertise displayed as they work through this real medical problem seems incredible for students who have only begun their first year. The entire educational philosophy of McMaster focuses on this form of small group interactive learning. This fresh approach to medical education has gained widespread attention around the world because it concentrates on what future doctors will need most. Not knowledge itself, but the skills required to keep up with change and to seek out the essential information.
And that's another theory, and I don't think it's necessarily proven for all the types of cancer.
Is that what you're
And
suggesting now?
I wasn't suggesting that at all. What I was saying, I was wondering if you would necessarily have to get lymph nodes involved in the axilla before you get that one, or could it be possible that the cells
Go right through
and then end up...
It doesn't seem to be from what they've shown. Just whenever they find, just in almost every case it said, when you find tumor here, you will find tumor here, but not necessarily the other way around.
The program of self-directed learning demands a high level of curiosity and personal responsibility. According to Dr. Norman White, these are exactly the qualities that will be required by tomorrow's doctors.
I think to a very large extent we harness the enthusiasm of the students. In order to perform well in the McMaster system, people have to learn skills which they're not going to forget in a hurry, and they're precisely the same things they need to know in order to be able to survive and do well when they become professionals.
The kind of program they get is really the kind of program we would give to graduate students who we want to be scientists. You know, the ability to range over a subject in an inquiring way rather than assuming there's a body of knowledge that you must get under your belt. I mean, we spend a lot of time with graduate students undoing the damage done by their undergraduate years. And then we turn them into graduate students. Well, our medical students get the same approach, essentially. So that in a way, they begin to think, I would say, like a good scientist begins to think. They don't have much knowledge, perhaps, but they have the right approach.
Did I find yours? What did you get? Here's mine.
Linda?
Within only weeks of registration, the students pick up their stethoscopes and medical kits. Students here begin clinical work from the very start. In other schools, the clinical part usually follows 2 years of classroom training in the basic sciences.
Artery is just over this way, so just slide it over this way. Just tell us if we're tearing your skin apart there.
At McMaster, the textbook is no substitute for reality. In a matter of only weeks after enrollment, student Donna Goldman experiments with the realities of dealing with patients firsthand. Donna has elected to spend 1 full day each week with Dr. Steinberg for on-the-job training in the personal and medical aspects of the doctor-patient relationship. As a McMaster student, she is encouraged not to think of the medical problem in isolation, but to consider it within the context of the community at large and the patient's frame of mind.
What did you get?
140 over 84 or something.
Right, good, that's very close. Was there anything different that you noticed the way I did it as the way Donna did it? The blood pressure?
I was a lot slower.
Yeah, you're a lot slower pumping it up. And you didn't pump as high as he did. You're quicker, that's all. Experience.
Okay.
Yeah.
Good.
Is there a safety margin during which you can increase your blood pressure and not have to go off the pill? Or was it how high does it have to be up before you'll recommend a patient go off the pill?
And someone her age, it would be a diastolic, which would be above, say, 85 millimeters of mercury. And she was running diastolics well above that.
Blood pressure is normal, so you're happy.
All right. Yeah, you bet.
That's right.
It's been high for ages.
That's right. So the blood pressure's come down nicely.
Although students at McMaster don't have scheduled lectures, they still cover much of the same material as students in conventional medical schools. But when they study a traditional topic, like anatomy, they do so for very practical reasons, and not just to pass exams and then quickly forget it.
The adductor is at the bottom here. But anyhow, the four muscles we saw are all sitting in here.
And the opponents has been removed?
Right.
The opponents is deep.
Oh, okay.
It's in
So
there.
it's all in here, right? It's difficult to see.
Investigations into anatomy arise directly from practical problems that the students are already working on. Traditionally a nightmare of memorization, anatomy here is just another vehicle for learning the underlying concepts rather than amassing facts.
And here's the one that's splitting.
See when it splits?
Are they
This
attached
one.
together?
It splits and one ends at this
Here.
Oh,
Here's the one that keeps going,
Splits
split.
and this
The
comes up.
profundus pierces it.
Right? Right? So there's the split.
Hang on, this is two muscles. Is that just for fine control?
It allows one to act like a pulley.
Do they have this in every finger? Like,
Yes.
They're not very
It just
important.
goes to the proximal point.
Yes. Incidentally, some of the digital nerves, here's one of the digital nerves.
Is that one from the medial nerve and the other side from the ulnar nerve?
Yes, it would be.
On that finger.
Right. So
Is that why that finger's weaker?
Not really.
it's all fun in here.
Yes.
Anatomy, particularly anatomy, I think of all the subjects is the pits. Everybody recognizes this. Surgeons have to learn it to do surgery, but that's when most surgeons, of course, learn it. They forget pretty well everything they learned as a medical student, I've been told by surgeons. So it's a pleasure not to have to do that. On the other hand, I'm a scientist, and there are basic sciences that perhaps one worries about. You know, it's hard these days to understand some of the complexities of some of the disciplines without having a good grasp, say, of physics or chemistry.
People designing medical education programs have had to be very highly selective. There's always something which is left out. And our approach here is to try to help the students to learn the embodying ideas which enable them, as someone said, not to have to count the fall of every apple. So that they learn the concepts which underlie their thinking rather than having to accumulate vast stores of trivial knowledge.
The McMaster program is a bold experiment. By leaving the familiar territory of lecture halls and written examinations, these students assume a learning style that requires maturity and self-discipline. Even in the first year, they can extend their range of experience by completing part of their studies abroad, principally in the third world. The process of self-directed learning will better prepare them to deal with the explosion of knowledge they will confront when they graduate. Here, the familiar stresses of exams have been replaced by daily pressures to keep pace academically and to contribute to the general progress of their tutorial group. The kind of self-directed activity that you have here, it seems to me, puts a lot more pressure on you than the other more traditional.
Yeah, it does. It does. I think the pressure here is continuous, and it starts off in September in a mild kind of way, and it builds over the years. At a conventional school, you have to deal with exams, and that's incredibly pressure-packed, but for a very short period of time, and then it's over. Mm-hmm. Here, you're in charge of your own learning 100% of the time.
But you don't have traditional exams and quizzes and term papers to turn in. Is it more difficult to have to do it on your own?
It is. It's a stressful experience to really not know objectively with a percentile mark where you stand. On the other hand, it's useful in a sense because that's the way the world is once you get out. I mean, you always have to be able to evaluate yourself once you're out in practice. If you can't do it now, chances are you won't be able to do it very well later.
You're separated from your husband, or your husband?
Actually, I'm divorced.
You're divorced?
Yes.
So what's seemed to have been the problem recently?
Well, I just feel very tired all the time. It's not just the move. I just am tired. And I've lost all interest in things. It's not like me. And it all took me so much by surprise.
This is an actress. She's one of many who have been specially coached to act out an astonishing repertoire of symptoms. This gives students a chance to hone their skills and heighten their sensitivity to the needs of patients.
When did this tiredness start? With the move?
There's her thoughts, because she seems to be able to say, acknowledge what she's feeling.
She does, she does.
You sleep right through the night?
Sometimes, once I get to sleep, I do. I generally wake up early, though.
But it tends to take a while to get to sleep?
Yes, it does, yeah.
You lie awake thinking, or?
I try not. I try reading, and I take hot chocolate, but yes, I guess I do think a lot.
And they weren't just taught to have signs and symptoms, they were taught to have the psyche of the patient. You know, they would be mistrustful and, uncommunicative and all the things that patients can be. The idea has probably been around a while, because I remember when I was a medical student, we had this famous neurologist, and we had this Parkinson's patient, and he wanted to put him through his paces so that we could see a typical walking gait of Parkinson's. And he became very dissatisfied with the patient and finally jumped up and said, no, you're not doing it right at all. It's like this. And he then went around the room in a typical Parkinson's way, and the patient said, that's right, that's much better, that's right. And so, the idea that you can actually act it better than the patient can do it, because all patients are a little different, and what you want is a very typical example. That's the beauty of the simulated patient.
So tell us about the first simulated patient experience you had.
Oh, it was scary, to say the least. The first time that we had a simulated patient was actually during our orientation in our first week, and it was a surprise for all of us. And it was quite a serious simulation. We had to tell this lady that she had cancer, and it was a good exercise in communication. And I guess what they were doing was just throwing us into the fact that we have to learn how to communicate to people and to communicate to patients as people, not just as patients.
Find out which vertebrae.
And 11, 12.
This simulated patient is undergoing a thorough examination for a suspected heart problem. As she observes from the sidelines, the faculty tutor ensures that all of the required tests are carried out.
120/70.
After the physical, a student is selected to conduct an interview with the patient while the others watch on closed-circuit TV. Here, the patient's emotional well-being is as important as his physical condition. Interviews are evaluated as much on the student's sensitivity to the patient as on his diagnostic skills.
So you had the pressure, followed by pain that radiated kind of down your arm a bit.
You use that nicely as a little
And
summary.
you mentioned you felt shaken. Yeah. So what you were afraid of you do for a living? Scare him though.
Can you stop it? Stop it? Yeah.
I don't know if you really addressed, you gave him permission to be worried, or you told him it was good that he came, but I don't know if you really addressed what was bothering him.
He may think that he's going to die from this and that he could die from it at any time. Like you even said that this is serious and that it's good that you came in, but you haven't told him what it is that, that's so serious.
Well, because I don't know.
It may be very non-specific in his head that he's scared and he's saying, I've got symptoms that's going on in my chest. What's in there? I don't know. I don't even want to think about what's in there. A lot of men, as we've talked about before, won't say they're worried. They thought about it. They may have had a question about it. But to have a man say that he's alarmed, that carries a lot of weight to it.
I'm just wondering whether we're getting too much into his head as opposed to his heart problem.
I think they're both there.
If you can think of the two things happening simultaneously, because they do. And if you think for yourself, if you've got a pain somewhere, what those things might mean to you. And it's exactly the same for any person coming into your office with whatever complaint.
Every doctor will have to make decisions with life and death consequences. They'll have to weigh the benefits of treatment versus non-treatment and the resulting quality of life. Yet in most medical schools, ethics is simply a subject to get out of the way as quickly as possible. At McMaster, ethics is one of the underpinnings of the program and a vital part of every medical problem that the students will investigate.
I was wondering what sort of contact you have with the family physician and what sort of responsibilities you feel as a surgeon you owe the family physician. How much information should you be providing them about what you're doing? How much do you involve the family physician in your care, if at all?
Practically none.
Okay.
They get a report, they get the op note, they get the pathology record, and I see the patient twice a year and make a deal with them that it goes for life until one or the other of us goes first. I have no prediction as to who's going to go first.
As the problems become more complex, students are responsible for seeking out the appropriate specialists, such as cancer expert Dr. Mueller, for more informed opinions. These discussions naturally lead into the consideration of elusive and often troubling ethical questions that confront doctors daily.
Had a total mastectomy.
How do you decide on the size of that patch?
You're the surgeon at the operating room.
Okay. So it's a very arbitrary thing.
The size of a person's breast.
Why, of course. I've seen some women whose breasts are hardly bigger than mine. I've seen some women whose breasts are bigger than your head. And so you can take a chunk that much out of that breast and never show a deformity. And you take a chunk that much out of my breast and my breast is gone. And so that has to be a local decision.
Does that introduce a lot of error based on
How do you measure the error?
I don't know.
Well, you see your
That must be a
ass
very difficult thing in a study like this to measure the area.
Difficult, but that's the way this study went.
Okay.
I personally would go along with Dr. Mueller and think that you should offer the patient the options, even if you've got a preference one way or the other, because it's ultimately going to affect them.
Sometimes when you say to people, well, you know, what do you think should be done? Here's the options. They'll say, gee, you know what the options are. You know what's better, you know. They wouldn't have come to you, you know. They say, if you don't know what's best,
they're making
forget
the
it.
decision to turn over the control to you. That in itself is a conscious decision. They're saying, I relinquish my rights to choose, but they've at least had the right to relinquish the right.
Exactly. It's one thing to
The group will frequently continue a particularly thorny issue with other faculty members to help unravel the